Hi, my name is John Garvin. I'm the president and founder of benicoltd, an employee benefits consulting firm based in the far northwest suburbs of Chicago. We are pleased to present this video about the Affordable Care Act, the federal health care reform law enacted in March of 2010, and its implications for businesses and organizations of all sizes. First, let's review what's happened to date with this new law. On March 23rd of 2010, President Obama signed H.R. 3590, the Patient Protection and Affordable Care Act. Then on March 30th, 2010, H.R. 4872, the Health Care and Education Affordability Reconciliation Act of 2010, a companion package of fixes to H.R. 3590, was signed into law by President Obama. Taken together, the two measures make the most profound changes to our country's health care delivery and financing systems since the enactment of the Medicare and Medicaid programs in the 60s. For simplicity of reference, we refer to the law as the Affordable Care Act. Many provisions of the Affordable Care Act impact our citizens right away, while others take effect over the course of the next 7 years. What is really key to understand is the fact that there are over 1,000 occurrences in the law of the phrase, "the Secretary shall," referring to the Secretary of Health and Human Services. What this means is that the law, although verbose in its own respect, leaves a great deal of discretion around the promulgation of regulations to the Secretary of Health and Human Services as well as to the other agencies having jurisdiction, including the Department of Labor, the Internal Revenue Service, and the Centers for Medicare and Medicaid Services. Therefore, much of what employers will have to deal with in the future really is not yet known because of the incredible amount of discretion that was reserved for the regulatory agencies in the drafting of the law. By way of review, in the first year following the law's enactment, most of the private health insurance market reforms were enacted, including, number one, a mandate to make available coverage to adult children irrespective of their residency or dependency status until the age of 26. Second, the elimination of lifetime caps for essential health benefits and restrictions on annual limits for such. Third, the coverage of emergency services without prior authorization and at in-network levels of coverage regardless of the provider used. Fourth, insureds are able to designate any in-network doctor as their primary care physician, including OBGYNs and pediatricians. Fifth, coverage rescissions are only permitted for fraud or intentional misrepresentation of material fact and with prior notice to the insured. Sixth, a mandate to cover certain preventive care services without any cost sharing, in other words, 100% coverage. Seventh, elimination of pre-existing condition exclusions for dependent children under the age of 19. And eighth, a requirement that plans have both a documented and communicated claims and appeals process and external review process. Because of then presidential candidate Obama's promise in 2008 that if you like your health plan, you can keep it, a whole body of law and regulation quickly emerged around what's required for a plan to be grandfathered. Some of the market reforms I just mentioned do not apply to grandfathered plans, but as a practical matter, something on the order of 75 to 80% of all private plans at the end of 2011 either no longer have grandfathered status or starting in 2012 will no longer have it. Also in 2010, a small business health insurance tax credit program was initiated as a means to provide financial incentives for small businesses with less than 25 full-time equivalent employees to offer health insurance coverage. Without getting into a lot of detail here, the program potentially provides a tax credit of up to 50% of premiums for up to 2 years if the small business employer subsidizes at least half of the premium. To date, the volume of claims for the credit has been extraordinarily low. The main reason for the extremely low take-up rate being that the rules for the credit are complex and difficult at best to follow. This video was recorded in November of 2011. At the time of its recording so far this year, we have seen a number of changes resulting from the Affordable Care Act, including, number one, a new medical loss ratio requirement that individual and small employer group plans spend at least 80% and large employer group plans at least 85% of the premiums collected for medical care. As it is, self-insured plans are exempt from this requirement. Any plan that does not meet these requirements beginning this year must issue a rebate to consumers the following plan year. For employer-provided group health insurance plans, the amount of the rebate will be split between the employer and employee based on the employer's subsidy of the health insurance. Sounds like an accounting and compliance nightmare, right? There will be further guidance coming out on that, I'm sure. Point number 2, the tax on distributions from a health savings account that are not used for qualified medical expenses in 2011 increased from 10% to 20%. Third, over-the-counter drugs are no longer reimbursable under health savings accounts, medical FSAs, HRAs, and ARCH or MSAs unless they are prescribed by a doctor. Fourth, small employers with less than 100 employees are allowed to adopt new simple cafeteria plans. And fifth, implementation of the Community Living Assistance Services and Supports Program, which is commonly referred to as the CLASS Act, which would have created a new national public long-term care program, was halted in October of 2011 because, to quote Health and Human Services Secretary Kathleen Sebelius, she did not see a viable path forward for CLASS implementation. Next, starting in 2012, there are 2 major compliance requirements that employers will face. The first one has to do with a mandate that employers provide a summary of benefits and coverage explanation meeting specified criteria to all employees when they apply for coverage, when they enroll or re-enroll for coverage, when the policy is delivered, and if and when any material modification is made to the terms of their coverage. Regulations have not yet been written for this mandate, but the law states that the summary of benefits and coverage explanation must be no more than 4 pages in length, with print no smaller than a 12-point font, written in a culturally and linguistically appropriate manner, whatever that's supposed to be. And to boot, there is a $1,000 per enrollee fine for willful failure to provide the information in the manner and format that's prescribed through regulation, which, like most regulations, will be complaint-driven. The second requirement in 2012 has to do with tax reporting. In 2012, employers must include on the W-2s they issue in January of 2013 the aggregate cost of employer-sponsored health benefits for informational purposes only. On March 31st of 2011, though, the IRS issued guidance for employers that permits smaller employers, those filing fewer than 250 W-2 forms, to opt out of this reporting requirement in 2012. That said, beyond 2012, the W-2 reporting requirements for smaller employers are currently unknown, and one's ability to opt out as a smaller employer will remain in effect until further guidance is issued. Next, in 2013, new federal taxes come into play, namely, number 1, a new federal premium tax on fully insured and self-insured group health plans to fund comparative effectiveness research begins. Number 2, FSA contributions for medical expenses will be limited to $2,500 per year, with the cap annually indexed for inflation. Point number 3, there will be a Medicare payroll tax increase of 0.9% on self-employed individuals and employees with respect to earnings and wages received during the year above $200,000 for individuals and above $250,000 for joint filers. In addition, there will be a new 3.8% Medicare contribution on certain unearned income from individuals with adjusted gross incomes of over $200,000 and again, $250,000 for joint filers. Fourth point, and for those who itemize their federal income taxes, the threshold for deducting unreimbursed medical expenses will increase from 7.5% of adjusted gross income to 10% of adjusted gross income. Also, during 2013, all employers must provide notice to their employees informing them of the existence of state-based exchanges that are supposed to begin operating in 2014. Now, this brings us to 2014, which is the biggest year for change as a result of the Affordable Care Act. Whether you're an individual buying coverage on your own or a small employer up to 100 employees buying coverage for your employees, many rules for how that coverage works will be different. First, health insurance companies will no longer be able to turn anyone down for health insurance coverage or ask any questions about their health when coverage is applied for. In addition, strict rules for how much premiums may vary from one person to another will go into effect. Second, there will be a new market for health insurance in each state in addition to the sources of coverage that exist today. These new markets will be called exchanges. If a person doesn't have employer-sponsored coverage, he or she may be eligible for a subsidy to help pay for the cost of the coverage, and in some cases, an increased level of benefits with lower deductibles and copays by going through these state-based exchanges. Third, to go along with these changes, there will also be a requirement in 2014 that everyone carry a minimum level of health insurance coverage or be subject to a fine. This is commonly referred to as the individual mandate, and in fact is the principal subject of numerous lawsuits challenging the Affordable Care Act's constitutionality. Fourth, there will be a pay-or-play mandate for employers with more than 50 employees. Such employers will be required to offer a minimum threshold of health insurance coverage or potentially be subject to one or more fines. Employers could also be subject to fines if their employees choose government-subsidized coverage through the exchanges. Finally, last but not least, in 2018, we are going to all become very familiar with something called the Cadillac tax. This tax imposes a non-deductible excise penalty tax of 40% for any plan that's provided that's valued above $10,200 per year for single coverage and above $27,500 per year for family coverage. Second point is that thresholds are indexed and are increased for retirees and employees in high-risk professions. Third point, tax imposed on insurers or of insured plans and the employer or administrator of self-insured plans. Fourth, there will be allowance for plans to take into account age, gender, and certain other factors that impact premium costs. Fifth, the 40% tax would apply to the amount of the plan value in excess of the threshold. And finally, standalone vision and dental plans are not counted as taxable benefits for purposes of the excise tax. So in summary, absent either the Supreme Court next year upholding one of the appellate court's recent decisions that the law, specifically the individual mandate, is unconstitutional, or anything that might result from a political perspective following the 2012 election cycle, the fact of the matter is the Affordable Care Act clearly presents many challenges for employers of all sizes from both a compliance and tax perspective. At Benico, we stand ready to assist our employer clients with navigating through these uncharted waters. That concludes our overview about the Affordable Care Act and its implications for businesses and organizations of all sizes. If you have further questions about this subject or would like to consult with an employee benefits professional about how to develop and execute an employee benefits strategy around complying with this law, please give us a call at 847-669-4800. We're glad you joined us today, and we hope that you'll take the opportunity soon to view the other videos in our series around employee benefits concepts and ideas of interest to owners and managers of businesses. Thanks for viewing, and bye for now.